Part 6.
Part 6. This is the home stretch.
You keep saying that.
I know. I've jinxed us.
I think we can get through this. We can do this.
This
is good,
important.
This is important stuff. I'm glad we're starting fresh.
And there are a lot of questions on the critical care test about these medications and this process, so it's good to spend time on it. We're going to jump right into our paralytic agents, and we're going to start with sucks.
Yeah, so essentially there's two types of agents. You've got depolarizing and non-depolarizing.
Yes.
Now, there's really only one depolarizing agent, and that's succinylcholine. And this was kind of been the workhorse go-to for so long because it was fast onset and it
relatively
short
quick
half-life.
off, yeah.
It would go off pretty quick within like 10 minutes. And it made sense. There are some problems with it because physiologically how it works, it literally causes all of your muscles to contract or depolarize, and then they don't repolarize, and you just stay
depolarized.
Right, depolarized essentially. And that's how this one works. The problem with that is when you depolarize, all the potassium in that process leaves the cell in that depolarization and then doesn't come back in. So raising their potassium level a little, and most people's fine, and certain people it's not, and we're going to talk about who those people are.
Right.
But then comes along and I don't know, chronologically which one came first, but rocuronium is the big, at least in this region, is more popular as a non-depolarizing, and they found that if you push it, which we'll talk about it, but if you push it faster, if you give a higher dose, it has a faster onset, almost equal to the succinylcholine, and that's important, how quick the onset is.
The concern was the onset, yes. Because we're doing rapid. Remember, rapid means the medications. So if it took a long time to come on, it kind of interferes with that.
Yeah, especially when this is an airway that needs to be taken now. And so we give higher doses of that now, and it has almost the same onset within a few seconds. But with these non-depolarizing, they last longer. And then that begs the question, well, are we giving this hoping that, well, if we miss, at least it'll wear off soon?
No, we don't want to do that.
That's not our mindset. And so more and more people are going with rock now because it has less contraindications. That's the big thing. Whereas succinylcholine has all these contraindications, which we're going to talk about.
Yes.
But they're so rare.
The problem is they're rare, but they're also kind of hidden. It's not always clearly obvious that the patient has the risk.
Yeah, when you're going through your history with the patient, their succinylcholine isn't on their history of medications to not get.
Typically, people are not always aware that they have this problem. So we've had this slide up. We've talked about the time to effect and the duration. It's 1.5 mg per kg or 2 mg per kg in pediatric patients. And so, Josh, do you want to explain why that difference is higher in peds?
Well, it's actually very complicated. There's a number of reasons. No reason to go into all of them, but they have their children have a higher water content to their body than we do. Succinylcholine is water soluble. And so there's also the issue with they have different receptors on their cell membranes, their enzyme activities that break down succinylcholine are higher, tend to be higher in kids. So there's all these reasons that their body basically metabolizes it differently and faster. And so because you don't want to half paralyze somebody, we go with the higher dose to make sure that there's extra, and there are probably a lot of succinylcholine molecules left over. It's just to make sure that it doesn't get chewed up.
Because you can't over paralyze someone really, but you could under paralyze.
You can under paralyze.
So that's why neonates take an even larger milligram per kilogram dose.
You're right.
Okay.
Yeah. So younger kids, higher dose, and then also we're not going to go into it too much, but it does work in the acetylcholine pathways, right? And so this is the parasympathetic pathways, And so children are at high risk of bradycardia from this, especially if you end up giving second doses. So a lot of times they'll pre-treat with atropine. I don't think they do that as much anymore, but especially in neonates, they'll pre-treat them with atropine.
Because children, this is where you hear children have high vagal tone to begin with. They are already toned up that way, so it doesn't take much to stimulate.
Yeah, so you give an adult multiple doses of succinylcholine, they can get bradycardic as well, but children are even more prone to that. So you got to be aware of that. Have your atropine out. I don't know if we talked about in the earlier one, but one of the problems with pre-treating with atropine is then if you prevent bradycardia that comes on from hypoxia, and you don't recognize that, so it's a whole thing to consider. Just follow your department's protocols.
Yeah, absolutely. So that's our dosing tidbit. We talked about the time to effect. Again, 45 to 60 seconds. Most of these meds that we're talking about, that's about the time to effect. Duration, 6 to 10 minutes. So it wears off pretty quick. And then knowing that it is a depolarizing agent. And that's when we get into our contraindications, this is going to be important, and we'll talk about it. But it will cause fasciculations where they twitch, their muscles all twitch and kind of contract at the same time. But it is preferred. It's been used for many years. It's considered very safe under the proper indication. So it's rapid, it's short in action, it's pretty safe. Like we said, you can paralyze someone, which would be bad. So they generally lean to a higher dose in order to make sure that they're paralyzed. This is preferred because it can be given IM. So in the event that we have a patient that we cannot get any access on.
Which seems
weird.
Unlikely because we always can do the IOs, right?
I know. I feel like the IO is a sure thing.
But it is something to keep in mind as an option. If for some reason you're getting chased by a bad guy and you can inject him in the neck with succinylcholine
really?
and then keep running.
I guess. I think of I'm trying to think of a patient where we would have a hard time getting access. And I've had some fairly obese patients where even the yellow EZ-IO needle is not, it won't work on their proximal tibia because of the adipose and whatever. And at that point, your option is to go distal tibia. So if you don't know your landmarks for that, find it, because some people get more narrow at like a cartoon character at their feet. But not everyone. Some people are still really full of water down there. So you might not be able to get access. Maybe that's when this would count.
Maybe. Although then maybe they're so fat you can't get to the muscle either. It'd be intra-fat injection. Is that what that is?
Right. I think that obesity poses a lot of issues, and they're going to be our sick patients that need an airway pretty bad. But the cons, the potassium elevation, in even a normal, healthy adult, it can elevate it. 0.5 milliequivalents per liter. There are very specific contraindications that we're going to talk about, and you need to know these for the test. They're rare, and it's a small number of the patient population that has these contraindications, but you will be tested on them.
Yeah. Now, just to look at that, potassium can go up by 0.5 milliequivalents per liter. That's fine in a normal person, but anyone who is hyperkalemic, and they're right on the threshold, they're already showing little signs of ectopy and stuff. I mean, this could be the difference between
point,
perfusing rhythm and cardiac arrest, right? So,
yeah, we don't want to cause that. So as we jump into contraindications, this is why when you have surgery, they ask if it's the first time you've had surgery, they ask about malignant hyperthermia, and that is a genetically mediated disorder that you have
That you don't know you have.
You don't know unless you've been given sucks, or there's a couple of the inhaled gas anesthetics that can cause it as well.
So they'll ask you about family history, because if anyone in your family has it, is genetic, and so then they'll adjust their plan, their sedation plan.
It's very dangerous. It has a fatality rate that even with good treatment, as I understand it, it can be 5%. So it's a scary thing if this happens. Pretty rare, but be aware of it. Hyperkalemia, this is a known side effect. So in someone who's at more risk, we definitely want to be aware of that. We don't give this in patients who we know have a risk that would make them more prone to have potassium dumped out of their cells. And we're going to talk a little bit about some of those. The patients that have this receptor upregulation could be stroke or spinal cord injury patient. We're going to talk about that. Any multiple sclerosis or inherited muscular dystrophies. So let's first talk about what upregulation means. It means that when through some either injury or disorder, your muscle is not firing like it should, it is becoming weaker and it's atrophying because of the lack of use. Well, your body naturally creates more of these acetylcholine receptors because it's trying to basically reach out for any stimulus it can to give
if there's more receptors, there's more likely it'll get a stimulus.
Yes. So your body naturally does this. And it after some sort of an injury, within 24 hours, it's already upregulated quite a bit. Now, that goes with our stroke and our spinal cord injuries. But, so you see the 72-hour mark, that's kind of where they say it's not safe to give succinylcholine. It applies also with burns, but we're going to talk specifically about our multiple sclerosis patients or our muscular dystrophy patients here. Let's talk about muscular dystrophy first. So muscular dystrophy is an umbrella term that covers a bunch of different disorders. Usually these are genetically inherited disorders. And the two that you probably need to know the most about for your test would be like Duchenne's muscular dystrophy and one called Becker. But there is, I think, 7 or 8 really kind of common muscular dystrophies.
Do you think they're going to trick them on a test and say a muscular dystrophy that isn't?
I don't. I think
it's all muscular dystrophy. Just
yes.
Assume muscular dystrophy. Boom,
it's all the same.
Don't give it.
So the idea is that your muscles are kind of, this muscle cells are in like a long skeletal muscle fiber, and it's surrounded by a membrane, and the interworkings of that all together help your muscles contract and do what they're supposed to do. Well, in muscular dystrophy, you have a lack. I mean, there's a few other things that go along with it, but you have a lack of dystrophin, which think of that as like what makes the membrane of the cells really hold together.
Robust?
Yeah. So without it, they have a weak cell membrane. And that weak cell membrane puts them at risk for damage of the cell when they have this vesiculation all over. And it's compounded because as these patients progress, it usually starts in their youth when they're children. As they progress and get weaker and weaker, their muscles atrophy. And so those cells are at risk for damage just because they're atrophied. So these guys have a twofold thing. Well, a cell wall that's weak, that will be damaged easily with a vesiculation, then the internal potassium, the cell potassium, leaks out really quickly. Our cell potassium in our blood or inside the cell is about 140.
About the same as our sodium is extracellular.
Yes, but
our extracellular potassium is 3.5 to 5 is the normal range.
Yes.
So all of a sudden you break open a cell that's got 140 milliequivalents per liter inside of that.
Or multiple cells.
Yeah, well, it's got to be, right?
Yeah.
Multiple cells.
but that's where they get this huge influx all of a sudden of their potassium, and it puts them at immediate risk. So that's where that always in the slide is showing, because it's not a delayed process, because it's not like 72 hours later it's a problem. No, they're at a problem right now with this. Now, I feel like, Josh, I need to go over, just because I know that on the test it's going to ask, well, you could get asked about the finer differences between muscular dystrophy, multiple sclerosis, myasthenia gravis, however you pronounce that, and ALS, or amyotrophic lateral sclerosis, which is Lou Gehrig's disease. And they're very similar because they all result in weakness, muscle weakness. But it's
do they all put a patient at risk who gets succinylcholine?
Yes, they do. Because anyone who has the muscle atrophy, they have a problem with the upregulated receptors. So they have lots of receptors on the muscles that are working, and their cell walls get weaker, but not for the same reason that they do in muscular dystrophy. It's that they are not used. Just like anything, it just weakens all over. So let's just review really quickly. Muscular dystrophy is usually genetically inherited, and it starts with that lack of dystrophin, and it's right in the muscle cell. And then multiple sclerosis causes muscle weakness, but it is because it is an autoimmune disorder that attacks the myelin sheath on the neuron. So it's affecting the neuron, so to speak. All right. And then myasthenia gravis is another neuron type issue, but it's at the junction, at the neuromuscular junction. It's an autoimmune disorder that attacks that area. And at last, ALS, or Lou Gehrig's disease, it has a...
One thing you don't ever want in life is to have a disease named after you.
Good. That's a good point. That is a good point. ALS is...
A building or a road, even a road. Sometimes that's pretty tragic.
Maybe. But just remember, ALS is in the spinal cord and the brainstem. And it's a sclerotic disorder as well. So it causes like scar tissue or hardening. If you hear sclerotic, think hardening or scar tissue.
Not in a good way.
Not in a good way. And so they literally have their lateral spinal cord nerves get hardened. That's why you get amyotrophic lateral sclerosis. And it's probably why they called it Lou Gehrig's disease, because it's easier to say.
Yeah. Well,
but these patients not only are all at risk for this problem, but these are all patients that could need airway management because of their muscle weakness. They could
respiratory muscle weakness, going to respiratory failure.
Yeah. They could have
or infections, pneumonia.
Their diaphragm not working properly because of the muscular weakness. It's kind of a double-edged sword, because they might need it, but they shouldn't have it. So we need to use a different neuromuscular blockade with them. Burns, same reason. They upregulate within that 72 hours, and you give it to them at that point, and it will cause a massive shift of potassium. So we don't want to do that.
You were telling me, which I did not realize this, like up to 72 hours, but even over a year.
Well, that's what in the literature, it said that they should be considered a contraindication for up to a year, because depending on how bad the burn or injury is, even a stroke patient, until their body regulates that area that was damaged, which I found surprising, because I don't know that I would recognize that as a contraindication, but it's something to be aware of. Crush injuries, again, you've got the damaged cells, and they've released the potassium from those cells at the time of the injury.
So they're already going to be hyperkalemic.
Yes, but then within 72 hours, their other cells have upregulated to try to account for it. It's almost like a compensatory mechanism our body has to create those receptors. So just be acutely aware of this, especially with the test. They love to ask about obscure medical conditions. That's like their favorite thing. Let's talk about malignant hyperthermia. It is triggered by a lack of a certain gene. We're not going to get into all of that, but you have a predisposition based on your genetics for it. And succinylcholine, as well as some of the volatile anesthetic agents that they use, like isoflurane. Really, the clinical features of this would be increasing end-tidal. That's the most reliable indicator that they are in a hypermetabolic state. That's what you've created by giving this to someone with this predisposition. It's now they're hypermetabolic, so they're burning off like everything.
It's a good weight loss program.
I don't think so. They'll be in a sinus tac, maybe PVCs because you're irritating it, because they also release potassium. Remember, that's like the big thing. So depending on where they are, it could cause some cardiac irritability. Muscle rigidity, especially in their masseter muscle. So like they become like sustained rigid, and that is what's creating this heat. Their core temperature rises, and they will have myoglobinuria, which that's going to be a little bit later, but it's almost like a compartment or a crush syndrome in the
that's
the
what clogs
release.
your kidneys when in those crush syndromes.
That's why they have the tea-colored urine.
Yeah.
Yes, but it's the sustained muscle contraction that produces a depletion of the adenosine triphosphate, and that increases oxygen consumption, carbon dioxide production, and heat. So they're not having a fever because they're like sick with a bacteria. We've created this reaction in their body because they don't have the same mediators that a normal person has. So literally, the depletion of ATP leads to the membrane failure of the cell, and the cell content leaks out, which gives them hyper K, which makes this whole situation worse. So that's why we ask about it. It's important to know because I guarantee you're going to get asked about it on a test. So knowing the treatment is important. There is a hotline, almost like the Poison Control Center, except for its malignant hyperthermia hotline. You want to give
I
them...
wonder how many people staff that.
I
How
don't
often
know.
does this happen?
I have no idea. That's weird. But we want to give them lots of oxygen. They're burning through oxygen, just like any of our patients who are in a hypermetabolic state. They're burning up their oxygen. Dantrolene, you need to know this for the test. Dantrolene is the drug of choice to treat this, and the dose is 2.5 mg per kg, rapid IV push. So make a note of that, highlight it, whatever. You need to treat the hyper K separately. Dantrolene, while we won't get into the details, but it does affect your calcium, the way that the calcium moves. You need to treat the hyper K, and knowing how to treat that is important, but I don't think we're going to talk about that right now.
No.
Monitor their glucose. Why would we monitor their glucose, Josh, when someone's hypermetabolic?
Because it takes glucose to make energy.
They're burning it up. Yep, they're going to become hypoglycemic. And keep them cool. Passive cooling is one of our ways, at least in the field, that we don't have a lot of other methods. So be aware of this for the test.
All right. And you see 39 degrees Celsius. I know a lot of us aren't comfortable with Celsius, but it's what's used in the hospital mainly. So if you can just remember a few numbers, then you can kind of understand where patients are in their temperature. So 37 degrees Celsius, that's normal, 98.6. Okay. 38, that's the beginning of a fever. What is that, Rebecca?
100.4, I think.
Yeah, that's 100.4.
Yeah.
And then 39 is 102.2. So memorize that. And then 40 is kind of easy because it's 104 Fahrenheit. So that's just
Good
a little way to remember.
Keep in your back pocket.
Yeah.
I wish we had like an AC/DC for those about to rock. I don't know.
Hey, get some back and black for you.
I know. I'm going to that concert in a few months.
I know. You have to tell us
So
about it.
excited. The rocuronium non-depolarizing, so it's a neuromuscular blockade that does not depolarize the muscles. The dose 1.5 mg per kg. Sound familiar? But this does not change with our pediatric patients, which is interesting. The time to effect is 45 to 60 seconds again, but the duration, 45 minutes. That's, in comparison, it's much longer on its course of action.
There actually is a reversal agent now, but
you do need to know it.
Do you?
For
What
your
is it?
test, neostigmine.
Neostigmine. Yeah. It's super expensive. No one's going to carry it. Hospitals will carry it, but.
And my partner at work would just make fun of me for knowing that. Because I don't know, I have a bunch of useless information.
Rightfully so.
So the nice thing is that it doesn't have as many contraindications or risks involved when compared to sucks. So we changed cons really to cautions because it's less of a con and more of a caution when you're using rocuronium. The neurologic exam on your trauma patients is going to be difficult because this lasts for 45 minutes. So when they're evaluating them to take them to the OR, there's going to be some issues with that. And then your sedation, you have to be on top of it because they will be paralyzed for 45 minutes. And it's very important that they stay sedated.
I went to a small rural hospital once to pick up a patient, and the physician there did not understand that rocuronium is not a sedative, that it's a paralytic. Apparently, he didn't understand what that meant because as I walked in, he said, "Oh, good, you're here. Hey, if you want, I can hit her with another dose of rock to keep her sedated until you guys get up in the air."
Yikes.
And I said, "You sedated her with rock?" And he's like, "Yeah." And I look at my partner with big, big eyes, and I walk up to the patient and I open up her. I go to look at her pupils, and tears had built up under her eyelids. So when I opened it up, it's like the floodgates had just dumped down the side of her face. I threw my because where I worked, the nurse carried the Narcs intubation meds and everything. So I threw that at my partner, and I was like, "Get her sedated." And I leaned down and whispered in her ear. I said, "Hey, I understand that you're paralyzed right now. It's a medication that they gave you, and I know that you're completely awake. We're going to give you some medicine right now to make you go to sleep, and we're going to make this comfortable." And tried to calm her. But she'd been laying there paralyzed, fully awake for who knows how long.
That's terrifying. The important thing is that you have a plan for sedation, and it is preemptive. You are not waiting to figure out what you're doing to maintain their sedation. The idea that you can just wait and do it is not appropriate. You should have it done at the same time as you're getting all your meds ready. So whatever it is that you're going to maintain with, that's what you should have in the chamber ready to go. So, all right, let's talk about vecuronium, or VEC as we like to call it. It is one that you don't see in our world very often. Do you see it in the ICU?
Yeah, you see it in the ICU. We used to use it. It was kind of our bread and butter for paralytic. And now my ICU's gone to rock. But
it's a multi-step thing, isn't it? You have to mix it and do special dosing.
It's stored. It's in the vial is powder, so you have to reconstitute it and draw it up. The nice thing is it stores longer. Rocuronium has to be stored in refrigerated for it to last.
We have to replace ours regularly. I have it on my phone. It gives me an alert when we have to replace it. So it's pretty regular, but it requires mixing, and so it's usually not considered conducive to our world in the
rapid. We got to get this done now.
But it has a it's a little longer time to effect. So, but
another reason.
That's one of the things to know about it. Let's move on to our next positioning. So we've talked so much about this already, but the final positioning for your tube placement, if you have to have external laryngeal manipulation, they used to call it cricoid pressure, which is actually not what that was designed for. Do you want to talk about what cricoid pressure originated as?
There's the Selleck maneuver, and then there's cricoid pressure. Yeah, cricoid pressure is during bag mask ventilation.
Yes.
To basically you put your fingers on each side of the larynx and push, or the cricoid, I guess what they call it, cricoid pressure, but the larynx, and push posterior to collapse the esophagus so all the air magically goes into the trachea. That's the idea behind cricoid pressure.
So it was for BVM.
Yeah, the Sellinger technique is external laryngeal manipulation.
So there's a couple of ways to accomplish that, but we've talked about the alignment of the three axes. The idea is to know what your equipment is that you're working with. If I have direct, I have to have all those axes in line. If I am using a hyperangulated blade, I can look around the corner. I don't need to line them up exactly all in one, but I do need to adjust the patient's head, and we have a visual of that. So again, just a reminder of these oral, pharyngeal, and laryngeal axes. And have this consideration as you move forward. It is really quite impressive, the little bit of benefit a folded blanket under their head will do for your visualization. So keep that in mind as you move into any scene where you're going to have to intubate. Now, we didn't talk before about the Cormac-Lehane, and it's a grading. So think of the Mallampati as it's a score, it's a class. And so that's what you'd see first. And then Cormac-Lehane is a grade of the view of the airway, the view of the glottic opening. So you can see grade 1 is great. That's what we would like to see. Grade 2.
Well, it seems like that's what we would like to see, right?
Yeah.
Which there's something to say about that when we talk about the video scope. Well, we'll just say it now. So
yeah.
A grade 1 view is great. That's a perfect view, right? And if you have that view and you're using, a regular direct laryngoscopy technique, great.
Beautiful.
But if you have that view and you're using a video scope, that means you've got the video camera sitting right in front of the airway and you're blocking
way too close
your ET tube from being able to make access to the air hole.
And I work in 2 agencies. I use the glide scope in one and the McGrath in the other. And I do have to position the airway in a slightly different spot on the screen for the depth, because the glide scope we use is the hyperangulated. So it's getting to know your equipment is so important. Now, if you have a grade 4 view, that's not good.
No.
Honestly, my experience has been, if I can't see anything, I'm going to try a different piece of equipment for access to view it, because usually that will solve it for me. But sometimes it's a real crappy view.
Yeah, don't get locked into what you're doing now. If what you're doing is not working, change something. When I first started intubating, I loved the Mach 3 on a direct. That's what I mostly used to start out with. And I was so comfortable with it. Well, I had done it in the OR in my training. So I had done like 22 intubations at that point in the OR. And my very first intubation, I love to tell the story because it was a woman, a witnessed arrest, and she was Jabba the Hutt. When I walked in and saw that her chin just turned into her chest, I remember being like, this is my first field intubation. Like, this is what I get. So I went in with grab a 4?
No, I went in with my Mach 3 and I could see nothing but tissue. I had tried to find my landmarks. I just couldn't see anything. And up until that point, the Mach 4 felt like just so much metal in their mouth. But I was like, I can't put the tube in this way. So I clipped out of that and clipped in the Mach 4. And I put that in and it was like, the angels were there. It was. And so it got me over that really quick. So I look at, if I can't see anything, I'm going to change my blade or change my approach, because that usually will fix it. All right. Placement with proof. That's our next P. We have nowadays, years ago, we didn't have end title. And so now we have, well, we had end title with the colorimetric.
Sure, we did. Well, yeah. So we didn't have capnography. We had capnometry.
Capnometry
Gave you a number and a color.
Yeah.
Well, the color represented a number.
A number. So we now in the field have a waveform with a reading that's in real time. And so that's the gold standard for placement proof. But you should also have fogging in the tube. You should be able to auscultate, visualize it as it passes. I love the video scope because my partner that's bagging for me while I set up, I have it, and as I pass it, I say to them, watch this pass the cords, so that I have two sets of eyes watching. Because I know some places record it. I don't work at an agency that records the video scope. But making sure that you are in the trachea, that you're not in the stomach. Fun fact is that you will get an end tidal reading from the stomach. You will get an end tidal reading briefly. So, but it takes up to 6 breaths for it to register at 0, and sometimes more. So really, if you get a couple of breaths with an end tidal of 18 or something on a person that's very sick, maybe make sure that if you didn't really watch that thing past the cords, make sure that you're not losing your waveform and the numbers not dropping actively.
Yeah, you could also get waveform if your tip is sitting just outside the glottic opening, which is your hypopharyngeal space. However, at what will be a little alarming to you if you're like, oh, we've got good waveform, but that tube's going to be sticking a foot out of their mouth.
Way out.
They're not going to be at 21 at the teeth.
I'm sure that we don't need to remind everyone, but generally your depth at the teeth is 3 times your tube size. And so if you're using a 7.0, that's about 21. And I always try to announce it when I put a tube in. I say out loud, okay, we're at 20 at the teeth, or what, I say it out loud mostly because Rebecca hears herself. And then after we've moved the patient and I'm checking again, I can remember where it was. So,
one thing I don't have on here. So I did actually have a patient last week, actually it's this week, who, we intubated him with a 7.5 tube. This was in the hospital. Had it at 26 at the teeth. Right, which seems very
way deep. Yeah.
The reason we started it there was because he had been intubated 2 days before, and that was where it was at. So put it at 26 at the teeth. Chest X-ray, which is a way to verify depth of the ET tube, is standard in hospitals. That post intubation, you always get a chest X-ray, and that's to determine the depth of your ET tube. Well, even 26 at the teeth, so you think this would be pretty close to the carina.
Yeah.
It was like 6.7 centimeters above the carina.
How tall was this guy?
Right? I mean, he was mid-6s, but, and so if you remember, depth above the carina is 5 centimeters plus or minus 2, so you can be anywhere from 3 centimeters above the carina to 7. So this guy's just barely in that range, and it's buried to 26. He was just super tall. You wouldn't know out in the field if you put this at 21 at the teeth. It was a 7.5, so say you put it at 23 at the teeth.
Right.
It would have been almost extubated. So
that's a good point.
Anyway, but just one thing to with chest X-rays, and I think you may see this on a test, is they can verify the depth of the tube, but they cannot verify the placement of the tube, because if the tube's in the esophagus, which sits right behind the trachea, the chest X-ray can't decipher
which tube
it's in. It's just how high it is in the body, and
Did
so
you put it in the air hole or the food hole.
Yeah, so we use that as a tool, but that's to measure depth. And then once you see where it's at, then the RT will go in, usually in the hospital anyways. They'll go in and adjust it, but you can do the same thing. Deflate the cuff, move it forward 2 centimeters if it needs to go deeper or whatever. Reinflate, and then you're good.
I have put a blade back in a mouth to verify that as I move it, I don't dislodge it. I've just watched.
That's not bad, and that is nice now with video scopes. Mm-hmm. It's really easy to do.
It's super easy. The esophageal detection device, the EDD, is a bulb, and it's supposed to, you plug it onto the end of the ET tube after it's placed. And I've seen this used, and I saw food contents come back up the tube when they let it go, which that was pretty sure that it was in the esophagus at that point. But it's supposed to not pop back open if you are in the esophagus. It stays collapsed because the esophagus is soft and pliable, and the trachea is rigid with rings of cartilage. So that's one of the ways you test.
Yeah, and then it is fine to leave it on the slide, but just so you're all aware, because you don't really deal with this much until you are transferring patients that are already intubated. Every time you move a patient,
check.
You have to reconfirm ET tube placement through at least 2 methods, right? So capnography is 1, 2, and also this depends on your protocols, but 2 might be chest rise or listening to lung sounds. Sometimes you're just, things are got to move fast. Yes. So like chest is rising, our vent settings are not alarming.
Right.
There's capnography.
I have fogging in the tube.
We're good.
But
in your charting, you've got to document at least 2 ways that you verified after every movement. So moving from the ER gurney to the gurney that you're taking out to the ambulance.
Yes.
And then moving from that gurney back to the hospital gurney where you're transferring him to. Every time you got a chart that you check that it was still in place. Thanks.
Now, Josh talked a little bit about this first bullet point on post-intubation management. This is our last P. So the chest x-ray, that is like going to tell you your depth and tell you if you're in a correct depth. So he talked about the parameters for that. We need to secure the tube. This I cannot stress enough, but confirm placement after each move and prior to handoff. But I see people tying that tube down before they've confirmed placement. And I'm like, no, we gotta make sure. I need 5 or 6 breaths that I know I've got good waveform, steady number on my end tidal, and everything is cool. Then I will tie it. I can hold it. I can hold it in place for that amount of time, because I don't want to have to be taking the tie and the equipment off, because I like to tie and then tape with the twill tape, and then put sticky tape on it.
If you're using twill tape, however method you use to secure the tube, know how to do it, because I've seen people use twill tape and they just put the little overhand, lark's foot.
Yeah.
But they don't crank it down or tie an extra knot in it, and then it starts sliding in and out. So if you're using twill tape, make sure you know how to secure that. You use that tape method, which is effective.
Just putting a little piece of sticky tape around. Once I know where we're at, and everything's good, I lark's foot it, but then little piece of sticky tape. Now there's the tube tamers. What are they called? The tube securing. They have the bite block.
Just any commercial securing device. The thing I don't like about a lot of these is you can't measure where it is at the teeth.
Once it's in, you can't really see it anymore.
So what you need to do is verify where you are at the teeth or gums, whatever you're using. Put it on, and then I take a Sharpie and mark a line.
Very
you
good.
do that too.
Yes. Yeah.
And so now you know if you can't see the Sharpie line anymore.
It's moved. And it does not hold them. It will slide. I've had that happen. I also like the twill tape, because if I need to put the blade back in, if I am checking to make sure that it's still in place, I don't have to take the twill tape off. And people say there's no bite block. I have put an OPA in with the tube, because it acts as a bite block. It doesn't interfere with anything.
And that works. Yeah. If we have a patient start biting the tube,
They need some sedation.
Yeah, that's your real problem right there is sedation management. Also, if for some reason you do need a bite block, we would just take like a 5cc syringe and tape it to the ET tube. Put it in the mouth next to the ET tube and then tape it.
Oh, that's a great idea.
Yeah,
I've
we'd
never
use that a
heard
lot. At the other agency I work at, we still have these devices. No one uses them, but they're still around from however many tens of 20s of 30s years ago. It's a screw wedge.
Yes, I know exactly.
You put it in
I've
and
used
twist
one.
and crank their jaw open with it, I guess.
Yeah. If somebody's like, the idea was if they were clenching, and they're unconscious, you can put that wedge in a little gap in their teeth, and with pressure, you twist it, and it literally pries open.
Screws into their mouth.
I didn't ever have luck with it, but whatever.
We don't need to worry about that because we have RSI.
Yeah, we can take away all of their muscle tone. The next step is manage your ventilator. And we have a whole separate lecture on ventilator, but you do need to remember the DOPE acronym for checking ventilator problems. So check that with the ventilator lecture because you will need to know that.
I mean, real quickly, it's dislodgement, obstruction, pneumothorax, or equipment
failure. And it's in that order, I think. Continuous sedation, we talked about that. Using a sedation scale like the Richmond Agitation Sedation Scale or the RAS scale is, I think, a very good method of confirming in your documentation that you were checking for your sedation level. In the state of Utah, where we work, this is now part of the state protocol when you've sedated someone. So I think it's a great metric to use.
Yeah.
Now,
that being said, there's something to be said about sedating a patient in a nice, quiet ICU room and sedating a patient who you're moving from nice, warm ER out to the freezing cold tundra of Wyoming into a cold, loud helicopter that's right? So it takes a lot more medication to keep these patients sedated.
With all that stimulus.
Right. And so while it is nice to have a patient sedated at a nice -1 where you can say their name and their eyes open, right? That's not realistic for transport. So we do use this, but honestly, in transport, you're gorking your patients. You really are.
That's the medical term.
Because the alternative is, and I've had this happen, like they go from 0 to 60 and all of a sudden they're sitting up and reaching for their tube and extubating themselves. And I've had that happen. So you don't want to take that risk.
Keep them well sedated.
Which the other thing I don't know if it's on here. We don't really have this. Any patient who's intubated in the ICU is also their hands are restrained. So they can't accidentally extubate, and it goes the same in the field. Once you've intubated your patient, you restrain their hands.
That's a good point. I've not ever restrained a patient's hands yet.
There's ways to do it if you have like a certain way you wrap your patients in we'll wrap them up like a burrito with these transport blankets that we had. But if I'm not comfortable with that, keeping their hands in, because if they do start to wake up or something, you can tie a restraint around each wrist, right? And then you loop that underneath one leg, and then tie it behind their leg. So if they go to reach up, their leg is what's actually holding them.
Oh.
So their hands can't get up to their face. If you put it onto and then they're anchored to themselves, whereas if you anchor them to your gurney, or if you have a litter in a helicopter, right, and you move that litter, they're anchored to that litter. If for some reason something were to happen,
that makes so much sense.
Tied to that. So you can anchor them to themselves. It's a little trick that I learned.
I think Josh is just this wealth of tricks and tips. Now, ongoing paralysis, sometimes that's a thing. Usually we're dropping them off before the
I've had the ongoing paralysis patient before, which was this was middle of the night transport out of Montana in the dead of winter. They're always on ECMO and balloon
Oh,
pump
jeez.
with an open chest, right?
Yeah.
They could not afford to have, this wasn't our protocol to keep them paralyzed, but this was,
The sending
which
facility?
I hadn't, this was my first time having this open heart patient. So they were on a paralytic drip. We didn't carry that drip. I can't remember if we just used it up and then switched to rock when it was out, but some people do have to stay paralyzed because you can't risk them moving and
At all.
dislodging some tube
Yeah,
that
I
they
bet
bleed
that was a
out
quick
immediately.
pickup. I bet it was just like,
Oh
move
my
him over. Let's go.
Oh, the story goes on. Because then the airplane couldn't get de-iced because the de-icer was broken. And so we waited in this ice-cold fuselage for a de-icer from the next airport to come, and we're running out of medication. It was a nightmare. But anyways, so there is a time, but it's really rare that they're continuously paralyzed. And then, honestly, when I started in the flight world, I was so used to... you don't paralyze your patient if they're fighting the vent or whatever. You sedate them. But sometimes in the transport environment, there's so much stimulation, you can't keep them sedated enough, and they're coughing, biting their tube, biting the vent. And even though they're not awake, their body's responding to that. So there are situations where
You might need to.
I'll just paralyze them, and then I'll just do my best at maintaining their sedation package. But some patients just, you can't get them sedated enough to handle the vent. And then the other thing is ventilator settings. Some ventilator settings are more comfortable, and I mean, the best person to get them to that perfect vent setting is going to be your respiratory therapist. So I always had my RT friends on speed dial. I could ask them, hey, this is what's going on, and they could say, try adjusting this or that. But those are just some things to consider.
I love that you brought that up, because I think in our profession, in the field at least, it's considered like we're alone. We're kind of alone with our little team, and that's all we've got. But if you look at how physicians operate, they are constantly calling other physicians for
They get a
consult,
consult for anything.
for everything, and it's considered admirable. It's so the fact that you've got a friend, because we have a mutual RT friend who was like, call me anytime. I was like, that's fantastic, because when you are in a 45-hour-long transport with a sick patient and they're on a vent and you're not able to troubleshoot what's going on.
45-hour-long transport.
45 minutes to an hour is what I meant.
Right. Where are you transporting from? Tahiti? On a boat?
No, I can't talk. It's been a long lecture. This has been a long lecture. So just keep that in mind. It's good to reach out for consult. The last bullet point here is managing your adverse physiological effects that you create with intubation. And we talked about that with...
Back to that whole crash thing.
Yes. Keep that in mind. Trend your patient from before all the way through your care, because if they start to show signs of deteriorating, you need to manage that quickly. Okay, we're going to just talk about a couple of special considerations. I know that this is something we did mention before, but our geriatric patients, we have some physiological changes that can affect your airway management. We've already talked about their teeth if they're absent, or if they don't have the facial structure to help support bag mask ventilation. But osteoarthritis and osteoporosis can affect their ability to open their mouth and position the airway. We kind of showed some pictures of that when people have a kyphosis, or they've got head drop or something like that. Keep that in mind. Also remember that their pharmacodynamics and their pharmacokinetics are altered, and it's specific to their increased age. Anytime we have extreme ages, are very young or very old, we need to proceed carefully with our medicine.
Yeah, their water content is different. Their organs don't function as well.
The metabolism changes.
Everything.
Everything changes. So be aware of that. And then legal issues with our elderly, they might have an end of life directive like a pulsed. I've learned to read pulsed very carefully for what treatments and interventions they are okay with and which ones they are not. Because sometimes they're okay with chest compressions, no tube in the throat, or they'll have an IV but no chest compression. So just be aware of those legal issues that you need to understand before you treat some of these patients. Our other special consideration is our bariatric patient, and usually that means they have a BMI pretty high. A BMI greater than 35 is a predictor for difficult intubation, greater than 30, predictor for difficult mask ventilation. And part of that is just the pressures it's going to take to displace that tissue.
It's not a bad thing to ventilate someone with the head of bed elevated.
No, it helps you.
It helps a lot. It takes all that weight off the chest.
And this is a tip I got from an anesthesiologist, and I've used it now a number of times, but when you're sitting at that head of your patient and you're ventilating them and you're just not getting the pliability that you would like, he's like, just tip their head almost just 45, just a little bit to the left, on your left, like I guess it's your left and the patient's left, but just tip their head and ventilate there, and it does something and it makes it so much better. So fun facts that anesthesiologists can teach us. The physiological changes that we see in these bariatric patients is their chest wall and airway resistance. That's why it takes those higher pressures. Keep that in mind when you're using an extraglottic device, because they are not sucked to the epiglottis. If you push too much pressure, it's going to pop them off. And then their abdominal pressure pressing up against their diaphragm. They have decreased vital capacity. Their expiratory reserve volume and functional residual capacity, all of those are reduced. Ramp them. We've hit this so hard. I don't know if we can say it. We need to make a bumper sticker. I don't know. Ramp them so that you can decrease that airway resistance just with gravity. Any other things? We're good. All right. Good. The last thing I thought would be good to put in here is this chest x-ray showing a tube and showing the carina. I think we talked a little bit about the distal tip, like parameters, and this just gives a good visual. And then so can you talk about cuff pressures, because that's super important for flight, but it also is important in the ground.
Yeah. Well, first of all, just looking at this tube, so your ET tube has a radio opaque line on it that runs right to the tip. So you can see that line to right where the ET tube ends, and then sometimes the carinas kind of take some practice to find right where it is. But if you can zoom in on this, and if you can't see it on your screen, but 5 give or minus 2 centimeters above the carina. Yeah, as far as cuff pressures go, so something we didn't really used to talk about at all, and it's getting more talked about now, but they have these manometers that you can attach to your pilot tube to see what pressure your ET cuff is, and you want to keep that between 20 to 30. If it's too flat, then obviously fluids and such could get down into the airways. If it's too full and it's sitting there for a long time, it's just like if you sit on your hand for 5 seconds and then pull it away, it's white. Why is it white? Because it could not perfuse while you were sitting on it. Well, your mucosal lining of your airway, same thing. When you've got this cuff just pushing into it, it doesn't perfuse, and then they get necrotic mucosa and it sloughs off and all sorts of problems.
We don't want to damage their airway because of our actions.
These are very fragile tissue that we're dealing with.
It's really, they're cheap. Those manometers are cheap. We have a digital one, but we also have just the one that has the green, yellow, and red marking so that you know when you're.
Yeah. Now, with flight, this is an air-filled tube. So when you go back to Boyle's law,
Yeah.
you check your cuff pressures before you take off, and then at max altitude, you check them again, because as you go up, your cuff will expand and the pressures will increase, so then adjust accordingly. And then once you land, again, you're supposed to check the cuff pressures. So that's kind of the down and dirty of that. I will say I've kind of changed my practice a little. If that cuff kind of acts as an anchor to keep it on the other side of the vocal cords. And these ET tubes, sitting in this airway, and they get all the phlegm and stuff coming up, and things get slippery. And I've had patients extubate themselves with a cuff. It just slid like right out, So you don't want it too soft, because if something happens, or maybe tubing gets caught right and it pulls on it as you're moving them or whatever, sometimes that cuff helps along with your twill tape or whatever you've used to secure the device. So keep that in mind. So I always err on the higher, like more at 30 rather than 20, to just a little extra protection.
If you're keeping them connected to the BVM while you're moving them, I just think it's a bad idea. And I've had providers say, well, I don't want to lose the PEEP that I've built. I carry a tube clamp in my fanny pack, because you can just clamp that tube, and then you don't have any weight hanging on that tube to pull it as you move your patient. I just think it's not worth it.
That doesn't work in a spontaneously breathing patient, right? But if they're, but you gork them or they're paralyzed, that's fine. And we actually started doing that a lot during COVID, because that alveolar recruitment took place over time, that PEEP expanding. And so now you've got some good alveoli function and stuff. And if you disconnect and you lose all that in this patient who's ARDS, critically ill, and now their SATs are going to drop, and it's going to take a lot more time to get them back up. And while they're that low, cells are dying.
And it's traumatic to the alveoli to have that atelectasis, to have them collapse.
So in a really, really sick patient, definitely get some forceps or something, and you can just clamp the tube while you disconnect it from
the tube clamps that I carry, they just have like a vinyl covering, so they won't damage the tube. They're great.
Yeah, that should be standard equipment for transport.
I got mine on Amazon. All right, here's the last slide. It's just a reminder of the 7 Ps of intubation, of RSI. So if you need to quickly snap a picture or write that down, just know that mnemonic. And
I highlighted the reds because
of
everything. Those are so important. You have to pre-oxygenate them before you intubate them. And people get so confident. Oh, we can RSI now. And then they forget that it's not just about pushing drugs and putting a tube in. There's so much more involved.
Yeah. The patient's anatomy, that anatomically difficult airway, is about the placement of the tube, you having difficulty. The physiology, the difficult physiological airway, is safety for the patient. If you're not taking that into account, you could make things worse. The last thing we want is they would have been better if we didn't show up.
Yeah.
So, all right.
Hey, we did it.
We got to the end. Yay.
Thanks for hanging in there, everyone. Hope you enjoyed this.